All right, well, thank you everybody for joining us on this video. I have the distinct pleasure of having Gerry Chiricolo, an emergency physician from Brooklyn, New York, who's been joining me via phone. And really, Gerry, I really appreciate you joining us today. Gerry has come to us to try to give the rest of us across the country a little more insight as to what we're seeing in the New York area, and specifically how physicians facing the COVID epidemic can address their needs both in preparation but also kind of what we can expect going forward. So, Gerry, thank you very much for joining me.
Yeah, my pleasure to talk to you.
Yeah. So Gerry, I think first to start, I know you guys have been working, some crazy hours, and really thank you. And I know your patients are grateful that you're all there and helping them out. Can you tell us a little bit about kind of what life is like right now, both medically, but then also kind of throughout Brooklyn and kind of how everybody's dealing with this?
Yeah, well, it's really been, we've started receiving COVID patients from the first patient that tested positive till now. Life has been different pretty much on a day-to-day basis. The beginning, it was a lot of preparing. It was a lot of changing up processes, changing policies, deriving new policies, trying to increase hospital capacity, trying to rearrange how we intake these patients through the emergency department. Then the patient volume starts to get to a point where you have to trust the processes you put in place. You have to operationalize them to the best, most efficient way of your ability. And then it's shifting every day as to what the priorities and the needs are. And then you have to flex to address those needs. Currently, right now, we're in a very different state than we were 2 weeks ago. Our volume has shifted to the moderate to very high acuity patients, and the resources and the needs are very much different. Now it's having enough rooms, negative pressure rooms to intubate patients, to manage definitive airways on. It's about running cardiac arrests and resuscitations. It's about resource allocation, about inpatient capacity to handle this high acuity patient load. Whereas in the beginning, it was about managing more of the less sick ambulatory patients, educating patients to what to look out for, what to return for, trying to keep a clean ED and a COVID ED, to have split processes. Our volume got to the point where we had to deploy, really innovative ways in how to process new patients. But right now, I would say it's very high acuity patients who are decompensating very quickly, and all of the patients are demanding a lot of resources and a lot of time and effort from the care team.
Wow. Now, Gerry, how long do you think that was, that interval where you kind of saw the lower acuity patients, and then things really ramped up to kind of where you are now? Kind of what interval was that for you? And then do you think patients are waiting a little longer to come in, or this is just the disease process and as this spreads across the city?
So it was about a 2-week process where we'd still get high acuity patients, but you would say much lesser volume of those patients per day. I would say about 2/3 to 75% of our patients in the beginning were more ambulatory, and you were able to manage and discharge. And over a 2-week period, there was maybe a 2-day shift on where it went the complete other way, 75-25 or 2/3, 1/3, where it's more the acute patients are occupying the majority of our visits. I'm sorry, what was it, other than the shift in acuity of the time period?
I was just sorry. I was just wondering if you thought this was patients waiting a little longer, or if this is really just kind of the process of as this unfortunately is spreading.
I think unfortunately, as this being a pandemic on a new virus, I don't think really anybody knows the answer to that. I think really it'll be multifactorial. In large metropolitan areas and a city like New York, where it's sharing very compact quarters with, people kind of cohorted in very closed areas, it becomes very easily transmissible. And I think once it gets out into the population, and even furthermore, high-risk patient populations like those in the nursing home, those in dialysis centers, that the acuity just seems to really ramp up. So I think it's multifactorial. It's people who weren't tested early enough, who were asymptomatic or minimally symptomatic, not knowing if they had COVID, going to see people who are at high risk, them getting contracting the disease at a later date, and then ultimately, progressing to more severe disease. And I think that, it's still being transmitted out, even though there's some social distancing and isolation guidelines out there. I think, unfortunately, there are still people in New York that just can't isolate and social distance because apartments are small, quarters are tight. They still need to go to places to get their care. There are nursing homes, skilled nursing facilities, which really can't keep people too far apart, right?
Right.
Healthcare workers are getting sick. They're taking care of patients. They don't know they have it. I think it's multifactorial for sure.
No, I completely understand. Yeah, I think one thing I think everyone would like to know a little bit is, what did you do ahead of time? And I know you guys were one of the earliest and hardest hit. What preparation did you do ahead of time in kind of anticipation? And then for those people that have kind of seen what's happening in New York and New Orleans, Detroit, what could we do to prepare in other areas of the country to try to meet this and hopefully not be surprised by what comes?
Well, I think some of the key moves that we've done, and this is every step of the way of the patient's care, you kind of have to address this and come up with a process to how to intake these patients, how to manage these patients when they're in-house, and what to do about post-care management for these patients. Because, as they come in, I think what we did is we secured a tent. We put it in an area contiguous to the ED to try to cohort patients who could be screened, managed, tested, and either released or admitted from a tent area. We expanded our space of the ED. We fortunately had space that was near our current emergency department, and expanded our geographical footprint, but then also split the ED into a COVID area and a non-COVID area to try to keep one area clean, one area, quote unquote, contaminated, where providers can stay in PPE, kind of rotate around through rooms, make sure that there was an environmental service staff there to properly disinfect the rooms, wipe them down, do terminal cleans in those negative pressure rooms, all the while trying to maintain where healthcare workers weren't exposed to patients who potentially had COVID in the bed right next to them. So, right. Coming up with processes on the front end. Meanwhile, the ED was also working with the inpatient administrative team to try to increase capacity for negative pressure rooms, to increase capacity for contact and droplet precaution rooms, closed-door single rooms, but also massively expanding our ICU capacity because we knew what was going to come down the pike. But things that we implemented along the way that I think that helped, we had a no-visitor policy unless there was a specific and special need for the patient to have one caregiver with them. Obviously, pediatrics falls into that special population that should have a caregiver with them. But limiting the amount of people in the hospital environment that could be transmitting the disease was a really strategic step that we needed to take. Managing our PPE early, knowing what kind of stock we had, what kind of par level each department was going to have, how each department was going to manage that supply of PPE, I think was critical, because as we're starting to get resource limited in a lot of the PPE stuff, managing it early on was critical to extending the length of PPE availability to all the departments. We have a daily command center open, for resources that any department would need. It's a great group of people who can deploy resources in any given moment to the other sites. We've canceled elective outpatient surgeries, which freed up a lot more staff to be redeployed to ICUs and EDs and other areas that would need that staff, and goes from everybody from environmental services to transport to clerical staff. to nurses, to nurse practitioners, physicians' assistants, and even physicians. We implemented a very aggressive telemedicine platform to be able to do telemedicine visit callbacks on patients who were discharged that were a little tenuous or questionable, to make sure that they were being closely monitored at home, to see if they needed to return to the ED, and to give patients a resource to not even present to the emergency department if they had milder symptoms, where they could just do a telemedicine visit and a checkup through there. To have a process and protocols in place for, how you were going to manage staff, healthcare workers who developed symptomatology, who was going to be tested, how they were going to be quarantined, how long, what the return to work process was going to look like. It's really involved and pretty detailed for a conversation like this. But however you can prepare, the biggest thing would be conservation of PPE, ventilatory management, and really the biggest is surge capacity. Inpatient capacity, is probably one of the biggest things.
Right. If you don't mind me asking, how did you flex your ICU? So where did you find the extra ICU space? What other areas of the hospital? And then staff, you mentioned staff, and we've read and heard a lot about staff shortages from either being exposed and being in isolation. What kind of key policies have you used? And are you flexing your staff across different service lines just to really kind of an all hands on deck cross-training for multiple areas?
Well, so we flexed our ICUs, providing ICU care, and that's going to be different from institution to institution. Good areas to look at are step-down units, endoscopy suites, post-catheterization units, other ICUs like cardiothoracic ICUs, surgical ICUs, medical ICUs, pediatric ICUs. Trying to find the space and getting creative on how to maybe manage those patients in other areas, or transfer them to sister hospitals to increase the amount of capacity of bed spaces inside. You're going to have to look everywhere and anywhere to pretty much find space. In terms of the healthcare workers and how to manage that, again, that's really a lot of that guidance is done through the CDC and the State Department of Health leadership, and we kind of really follow their guidance very closely. But I think the key to any of this is prevention, and prevention is social distancing at work. Trying to make sure you cancel all of your conferences. You shouldn't have a lot of people in a room for any good reason. Use bridge lines, use Zoom conferences. You could connect and still do educational platforms or operational meetings remotely. You don't all have to be in the same room for most of these. So in order to keep our healthcare workers safe, prevention of wiping down the surfaces, proper educational modules on donning and doffing of PPE, when and how to use PPE, and work distancing in terms of these meetings and congregations during sign-outs and stuff like that were eliminated early on. So we were able to mitigate a lot of our healthcare workers from being sick, or at least being sick at the same time. And then we have a really good centralized healthcare workforce and safety department, which has been managing, the return to work and the management of these patients, as an outpatient while they're out of work.
Right. Now, thank you for sharing that. I know that's one area of big concern. And really, I think just one more question for you. And again, I really appreciate the time today. We've heard a lot about device shortages, ventilator shortages. We have seen, obviously, we're a dialysis technology company, so we've been following device shortages as well in our patients' area. What have you seen from that? Is there any sensationalism to that at this point? And how are you managing kind of critical shortages of devices across your hospital?
I can assure you, in New York City, there's no sensationalism going on. It's very real, and device shortages is a real problem everywhere, from something as simple as a cardiac monitor all the way down to ventilators and everything in between. And hemodialysis have temperature or fever detection at the dialysis sites, or even prior to going to the dialysis session. And those sites aren't equipped to handle these people who potentially could have COVID and contaminate the entire unit. So they're sending all these people to the hospital, to the emergency departments via ambulance. And you could you could be with 5 or 7 end-stage renal dialysis patients at a time, multiple times throughout the day, arriving to the emergency department, needing dialysis, missing a dialysis session, and on top of it could be pretty sick with COVID. So they're going to need inpatient dialysis, they're going to need outpatient dialysis, and without infrastructure set up or equipment to be set up to handle those patient populations, you're going to be overwhelmed very quickly. So I would say end-stage renal disease and hemodialysis patients, homeless patients who have fevers and coughs who aren't let back into their shelters, and nursing home or skilled nursing facility patients who get sent to the hospital. You have to have a process of where those patients are going to be sent to if they're stable enough for discharge, or as they're recovering from their inpatient illness, when are they going to be able to be accepted back? Because as those beds get filled, and they get filled very quickly, these patients are going to have no place to go, and being boarded or crowded in the emergency department just really prevents all these sick people from getting the initial care that they need. So the earlier you prepare for all of this, the better chance you have at success and survival the COVID crisis, because I got to tell you, we really are in crisis.
Yeah, no, I appreciate Jerry, you being willing to share all that with us, and really, please stay well. I know you're working around the clock, and again, I know the patients really do appreciate it. Thank you again for being willing to share your story with everybody. I know across the country, a lot of physicians are kind of wondering what may be coming down the pike, and again, your willingness to share what we should be preparing for as we look towards this, really helpful. So thank you again. Please keep yourself well and get some rest.
I appreciate that. You do as well.
All right. Thank you, Jerry.